Hello, this is Dr. Janson, and today I would like to present a case study that I thought you might be interested in. It's a patient who was told that she needs an ankle fusion, and this is a surgery that removes the cartilage of the ankle and fuses the bones together so that the foot can no longer flex. So this is a bit of a problem because if your foot doesn't flex, this can cause other joints to deteriorate. So it's a great stress on the knee, a stress on the hips and the back. I haven't seen very many successful ankle fusions because down the road they usually produce a lot of other problems. So if it were possible to avoid an ankle fusion, that would be really great for the patient, because then the patient can certainly walk more and walk faster. And the faster you walk as you get older, for some reason it's been proven over and over again, the speed at which you walk will determine your mental ability or your ability to remember things. For some reason, it's true. So if we could avoid an ankle fusion, you can keep up the speed of walking, which improves your mental capacity. And recently I've had 4 patients come in who were told they need ankle fusion, and I helped the patient and avoided ankle surgery on all 4 of the patients. So it seems to be a thing lately. So you might be watching this video. You are not this kind of patient, but I thought that it might be interesting to you to see what orthotics could do, because if I could help these people, certainly with your problem, I might be able to help you. So I thought it might be interesting. So the case that I would like to present to you today is a 72-year-old woman. She's a healthy woman, except that she does have Parkinson's disease, and this is a neurological disorder. It causes contractions and some issues with balance and problems with walking. The woman had a history of an ankle injury when she was young. I think she was a teenager. She had sprained her ankle, and the ankle never really healed properly. But with the Parkinson's disease, suddenly the ankle is moving inwards. So she's walking on the inside of, the outside of her foot, which is very unstable. So she's had this terrible problem. And she was very close to having ankle fusion. I think she was ready in only a month. She was only about a month away from having an ankle fusion. And then luckily she came in to see me, and I said, hey, there's no emergency for an ankle fusion. You could have it done now or 6 months from now, but maybe we could try this and see if this would work. And then if it did work, you'd be in a much better position than you would be if you had an ankle fusion. So that's the case study that I would like to present to you.
Well, I'm here with Dr. Janson. I've had an ankle problem for some time, and it's gotten pretty serious lately, so that it really impedes my walking. I saw a couple of ankle doctors. One recommended an ankle fusion, one recommended an ankle replacement. I'm here with Dr. Janson because I'm hoping that we can avoid the surgery, and she has some ideas about how to do that and has made me some orthotics that she's going to be giving me today. It was my freshman year in college when I was running from one place to another and didn't see a curve. So I stepped off the curb and the ankle twisted like this and was, I guess, pretty well messed up. I was on crutches for a while, but nobody ever prescribed any physical therapy or anything like that, so I guess it never quite healed itself properly. The ankle is often quite swollen. I don't have a full range of motion with it, but most seriously I can't easily bear weight on it, so it really messes me up when I'm trying to walk. It's very hard to walk any, not even a long distance, but even a city block can be difficult. I do hope that the orthotics will help the pain.
Okay, why don't you stand up now and then stand, and you can show like the position of it, how it wants to go inward.
So
but look at Joy though, but turn towards Joy.
The ankle wants to go this way all the time, but it hurts when it goes that way. So I'm constantly trying to force it to go this way, which is not easy for it, and I think that's what the orthotics will help me with. I've done a lot of physical therapy hoping to strengthen the calves and the ankle, and those certainly have helped, but they haven't fully addressed the problem, which is why I pursued the visits with the ankle surgeons.
Oh, that's patients are always buying me presents, so I've got so many presents over the last 30 years. Anyways, today we're making this very nice lady's orthotic. She was pre-op for ankle fusion when she saw me to see if orthotics could help her. So her problem is that her leg comes in at a certain angle, and then she's walking on the side of her foot. So in other words, her foot is very unstable. She walks, you know, her leg comes inward, so she walks on the side of the foot. So it's very unstable and very painful. So she saw an orthopedic surgeon, so he suggested that they fuse her ankle so her foot would be straight, but then she will be unable to move her foot. So that would make a very, you know, difficult and very slow gait with a very small, limited stride like that. It's about the stride when you can't move your ankle. Something like that. So here's the cast of the poor lady. So the first thing I'm going to do is I'm going to figure out like what is the upright perpendicular angle of the heel bone. So that's what I'm doing here. See? It's like perpendicular there. So we want this to be straight, you know, to the, like this, or perpendicular to the ground, I should say. So you see the problem is that when I hold this perpendicular to the ground, and you look over here, this is up in the air. And that's why she's so unstable. Now you might think that with the orthotic, we're going to make the orthotic that you'd want to fill that in. But actually that would be a mistake because it would just continue the instability there. Because remember, the problem is that the leg comes inward like that. So now we don't want to just evert the foot like that because we're sort of substituting problems. So what we want to do is we actually want to turn the orthotic up in the forefoot. So we really need to create support on the outside of the forefoot rather than here. So what I'm going to do is I'm going to carve away here. And we got to leave that bone alone because that bone has to hit the ground. But this is how I'm going to, this bone also has to hit the ground. So I'm going to remove plaster right here. I'm going to remove quite a bit of plaster because I need the ground to hit her here. And then I'm going to use a semi-flexible material so the orthotic can turn, and it'll help her when she's toeing off. Her foot will be very stable. I'm removing quite a bit of plaster here. You see how I'm doing that? Okay. And you see what I removed here? Quite a bit. Then when she walks, you see how she will land supported by the heel cup, and then this will be higher on this side. So now she's going to be nice and stable. Oop, she'll have a nice stable toe off when she goes to walk. See how I did that? Alright, now I'm going to make it smooth so I can make a nice orthotic. Make it all nice and smooth so she can't feel this and it won't bother her foot. We're doing it in the cast so we can get a lot of support, which is going to be very comfortable for her. You notice I didn't do anything with the heel. We're going to leave that heel alone. Because her ankle has arthritis, so we don't want to mess with the ankle. We want to just support it and keep it neutral. And the stability will come mid-foot to toe off. As the orthotic flexes and supports the outside of her foot when she goes on. See, I'm actually still removing plaster. Okay, see that? Looks kind of crazy. I'm gonna fill that in with a rubbery material, so it's not gonna bother her. But you see, that's a lot of support. You see that? How much support that is? All right, so I'm ready to make the orthotic now.
Okay, so today I'm helping the patient with this unstable ankle. The problem with the ankle is that it's going inward, and that's very unfortunate because it makes the whole side very unstable. So, and what the patient has been trying to do is pronate the foot or turn it outward as best she can, but she has little to no ability to do that. So I made a pair of orthotics for her, and this is the orthotic for the left side. And if I put it here, you can see how I have the orthotic, the heel of the orthotic built up more on the outside, so it prevents the foot from rotating inward. So if I hold the orthotic parallel to the weight-bearing surface, you see I put my two hands like this, and then I turn it here, you can see the angle, really see the angle of the rear foot of the orthotic. I think that you can see that it's, going this way. And what that does is so it doesn't allow the foot to invert. So the patient's been trying to evert her foot, but this orthotic will make it very easy for the foot to evert or pronate. And pronation is stability. So the whole leg should become more stable. And once it's more stable, then the physical therapy will work better because the muscles can get stronger with the foot in the right position. But with the foot inverted, those muscles are pulled and stretched to the limit. They'll never get strong. And that's why there's a limitation in the success of physical therapy when the foot is inverted. So, and the patient has some new shoes here. These are New Balance 990s. These are really good, stable shoes. So this is going to help a lot too. With this orthotic and these wonderful sneakers, and then the patient will go back to the physical therapy and working with the physiatrist, physical medicine doctor, who will prescribe different exercises, balance, and stuff like that. And the patient should be doing very well. And the most important thing is the patient will avoid ankle fusion. If the ankle doesn't flex, other joints there's destruction to other joints. So it's not a very good road to go down to fuse the ankle. So this is a much better road because the ankle will become strong and the patient will be able to push off on that foot normally and be able to walk a lot better and, in my opinion, live longer, actually.
And they feel good. But today Dr. Janson did some adjustments. I think they're going to feel even better. I definitely feel I need them to, without them I really can't walk very well at all. So that I know every day I put them on as soon as I possibly can when I get up so that I can wear them the whole day and be able to walk at all.
Oh, that's great. That's great. Why don't you walk for us a little bit down the hall so we can compare it to before and after.
Here you see, on the left, you see the patient barefoot, and the thick yellow line is the perpendicular to the heel bone. The thin yellow line is parallel to the heel bone. And then you see the angle to the ground here. The orange line represents the bisection of her leg. Normally, the bisection of the leg should be in line with the heel bone, but here you see it's not. There's about a 10 or 15 degree angle between the heel bone and the leg. And now look at the right. She's in her orthotics and in her sneakers, and you see the parallel to the heel is in line with the bisection to the leg. And also you see that the bottom of the sneaker is completely parallel to the weight-bearing surface, to the ground. So that looks very stable on the right.
It looks pretty good.
Feels good.
It's getting better.
Feels like it's getting better.
Okay. I think come in another month and we'll play with it again. Try to get you even, maybe even a little bit better.
Okay.
How's that sound?
Sounds good.
Okay, good.
Sounds good.